Okay, dear colleagues, let us start the ACNS Young Neurosurgeon webinar. Today we have three speakers. First, Professor Ahmad Ansari from Department of Neurosurgery, Jawaharlal Nehru Medical College, AMU, Eliart, UP, India. Young colleague 𝒊𝒒𝒒 Opra from she's a head of department of surgery at the Imo State Special Hospital over Nigeria, and our invited speaker, Professor Soichi Oya, Department of Neurosurgery, Gunma University Graduate School of Medicine, Japan. So Professor Ansari is presenting his experience of spine surgery, UB spine surgery, right pathology, left standing approach.
Yeah, sure. So thank you all of you for having me in here. At the outset, I would like to thank Professor Kato, Dr. Ben, Dr. Liu, and all the office bearers of ACNS ISMINS for having me in here. I'll be discussing my experiences with biportal endoscopic spine surgery. It's a relatively newer modality with the spine surgeons, and I'll be sharing our experiences with biportal endoscopic surgery. So the thing is, with biportal endoscopic surgery, we use the help of two different ports. For one for having the scope going inside the spinal cavity, and the other one through which the instruments go in, and through that thing we go and do the complete surgery. So it's a relatively newer modality, I would say, not too old, neither too new, and most of the pathology has been dealt with the right-handed surgeons. We stand on the left side of the patient. So at times, dealing with the pathology on the right side of the spine, most of the right-hand surgeons they tend to stand on the left on the right side of the patient. So I would be sharing my experiences, our experiences with the right side pathology of the spine and standing on the left side of the patient. A very brief is of UB. So it was in June 2013 when Jin Hua-yong and Sang Kyo-son from Korea they gave their first presentation for stenosis decompression on via the endoscopic route. It was in ISMINS, Japan, in Sapporo. Then in September 2013, again Sang Kyu-son from Korea, he gave the first presentation of endoscopic fusion. The first report on translaminar lumbar epidural endoscopy was given by Dr. D. Antonio de Clara, and endoscopic lumbar discectomy was first shared in his paper by Dr. Abdul Ghaffar in the year 2001. Again, the procedure for unilateral biportal endoscopy with for far lateral discectomy, it was first discussed in 2003 by Jin Hua-yong. So, as we see towards from the evolution, as we see towards the evolution of minimally invasive spine surgery, of course, starting with the open surgery, then going towards the tubular surgery, and then the new modality, the endoscopic spine surgery. What exactly is UB?
Go on,
So
go
it
on.
is based on scope surgery. It is based on scope surgery and is the same as the usage of arthroscopy as used by our orthopedics colleagues in joint surgery with the help of a fluid environment. Uh, Regarding biportal endoscopic surgery, we can use type of instruments as has been used in minimal invasive or microscopic surgeries without any limitations. It's more clean and safe, and it can provide more benefit to the patients. Where exactly we are regarding open surgery, we can use open surgery for almost all the indications, all cases, but it is a bit destructive. Microsurgery, again, it's less destructive, but still there are few limitations regarding the flow of the blood and the cleanage of the bony material, which is very handy and very helpful with regards to the usage of endoscopes. So where exactly are we? Regarding the usage with uniportal, that is with the usage of transforaminal and interlaminar endoscopic surgery, in the early days, it was minimally invasive but had limited indications. Recently, minimally, but again, it has gone into for wide indication with the device developing. With biportal endoscopic surgery, there is no limited indication with again minimal invasive spine surgery with surgery benefits. So again, the difference we can again see with regards to microscopic and tubular with regards to the endoscopic thing. With microscopic in the tubular, we have again to use the we have to take the help of suction in order to clean up the surgical field. With the endoscopic field, the best thing with regards to the fluid medium is the fluid in itself will act as a section and will drain, so it will wash out all the blood and all the unclean environment. So UB, again, it's the art of water flow. The inflow and outflow, it should be maintained very, very clearly. There should be a single cavity through which the water flows in and the water should be coming out. It should not be inside the body cavity at any point of time. So again, as we see, the operative field at the optimal pressure, it's around 30 to 50 millimeters of mercury through one of the sheaths through which the endoscope goes in, that acts as a saline input, and the other through which the instruments go in, uh, the fluid goes out through that port. The very basic of UV is the triangulation. Triangulation again means the two instruments, that is the scope, should be able to visualize the instrument that we are using. If it's an open triangulation, the instrument won't be visible. If it's an early triangulation, the instrument as well as the scope will collide with each other. So making a perfect triangulation is of utmost importance. Again, triangulation, one is the scopy portal, the other is the working portal. Skin marking, the second thing, it's of utmost importance. Now, regarding the skin marking, for simple pathologies, like for going in for a one-side nerve root decompression or for going for a simple discectomy, the on a lateral image, one of the most important thing is going for the mid portion of the spinous process and to check for the mid or for the upper part of the disc. On the AP view, again, we have to visualize the medial margin of the pedicle, mark it out, make our incision. Again, there is a bit of debate whether the incision should be a transverse one or a longitudinal one. For us, until and unless it is a fusion surgery, we more or less go in for a longitudinal incision. Again, the skin marking, as we can say, the medial margin of the pedicles are marked, and the mid portion of the pedicle are again taken into account. The very important thing is we can use the help of two spinal needles to get into shape the very point of the pathology where we should be handling our instruments. So I won't say that anything going in for the middle margin of the pedicle or midpoint of the facet and the spinous process should be taken. It all depends on the pathology that we are dealing with, whether we have to go for a stenotic decompression or we have to take out a simple nerve decompression or we have to get towards a discectomy. All that thing, all that pathology would mark how our incision is being placed. Now, in here, what we are seeing in here, the surgeon is a right-handed surgeon, and he is standing on the left side of the patient. We are very well see the 6 o'clock position is the lateral part, the 12 o'clock is towards the spinous process, the cranial side is at the 9 o'clock, and the caudal side is at the 3 o'clock. We can very well see that the whole cord can be easily decompressed standing from either the left side, and the same can be done if we are standing towards from the right side as well. So any side of the pathology can be dealt with from the right or left side. Again, for skin markings for foraminal stenosis, it's a bit different. The lateral view, it should be above the foramen directly, and on the AP view, it should be 1 centimeter lateral to the vertebra. What we are seeing over here is again decompression of the nerve root, which can be seen over here very clearly. The nerve root has been clearly decompressed. Now, this is again the surgeon is standing from the right side. Sorry, the surgeon is standing on the left side and dealing with a light for a left side pathology. For fusion things, again the skin markings are a bit different. What we are seeing, the red lines, again they are the skin incisions, and the direction, the yellow lines, what we are seeing is the direction of our ports as well as the scope, how it is going. The midline marking is the spinous process marking. Now, what we can see in here, the ports would be marking towards the spinal laminar junction, and we can hence clear out the whole spinal laminar junction, going towards that, and then moving laterally towards the facet joint. That's how the fusion can be marked out. Again, the very basic thing, how to create the potential space between lamina and the multifidus muscles. Now we can very well see that the first space, the potential space, is between the lamina and the multifidus. This space is created by the pressure of the saline that is being injected through the endoscope. The first space, as we can see on the left hand side, that's a potential space. After a bit of the decompression, starting from the spinal lamina junction and going towards the lateral side, we can say as the lamina is being removed, the true working space starts coming into view. In here, we can see the tone space, which is again the enlarged space between the multifidus muscle and the spinous process. Either during the initial stage of creating the muscle, we can take the help of small retractors, which we seldom do use. We can just chisel out the muscle from its attachment to from the spinous process and make an initial protection space, and then going towards making the initial working space. Now, for usual UV surgeries for left-sided pathology, if the surgeon is right-handed, the scope is towards the canal side and the working portal is towards the caudal side. Now, for right-side pathology, if a right-handed surgeon is using UV, most of the times the right-handed surgeon stand from on the right-hand side of the patient. In that case, this working portal, it goes towards the upper side, meaning towards the canal side, and the scopic portal, it stands on the left hand of the patient and hence on the caudal side. For us, we deal with the right hand for a right side pathology. We stand on the left side of the patient, and our incision markings is on the right of the spinous process. So for us, we don't remove the lamina on the left side. We directly go towards the right side of the spinous process and remove the lamina and deal with the pathology on the right side, standing on the left side. Now in here, what we are seeing in here, now this is another case in which the surgeon is right-handed and he is standing on the right side of the patient. The pathology has been dealt with clearly, and we can see the absolutely clear view of the decompressed nerve, the decompressed cord in here. Everything is absolutely clear. This is the surgeon standing on the right side, not on the left side. Again, this is another case which will be showing. So this was a very wonderful case. This patient had previously three different surgeries at different centers, in which firstly the patient had compression at L5-1. So the surgeon had fused L5-1 initially. The patient started developing pathology at the L4-5. It was again fused. L4-5-1 was fused. Again, the patient presented with a pathology at L3-4. It was again fused. So L3, 4, 5, and 1 was fused in this patient. She presented with again an adjacent segment disease at the level of L2-3. So what we did was a tit decompression with the help of two small incisions. One was a 7 to 8 millimeter incision, and the other was just a 5 millimeter incision. We decompressed the whole of the cord at that particular level. The initial incision, which was around 12 to 15 centimeters, this was just two small incisions, less than 1 centimeter. The patient was very happy just after the surgery and was discharged within 48 hours. So that this, I would say, there's the beauty of bipolar endoscopic surgery. So I would just demonstrate what exactly goes in with a simple demonstration of the surgeon is standing on the left side of the patient, the pathology is on the right side. So what we are seeing is the initial view when the scope goes in, and we have not yet inserted our instruments in here. That's the initial view. We are standing on the left side. The 6 o'clock position is towards the spinous process. The 12 o'clock is towards the facet side. 9 o'clock is towards the canal side, and 3 o'clock is towards the caudal side. What usually happens is when we are working when we are working with these surgeries and we are standing on the right side of the patient, all these scenario becomes just opposite. So at 6 o'clock, in that case, will be our lateral side. In this case, the 6 o'clock position is towards the spinous process side. So the initial thing, sorry. So initial thing, we have started making the space in here as the space is being built by the RF wand. What we can see is the RF wand is making space in here. This is the initial space. As we can see, we use different type of instruments to make the initial working space. Initial working space being built. We check the canal part of the inferior portion of the canal lamina. It's being checked out. Once we reach towards the canal side of the upper lamina, the space is being built. The space, once it is built, we start the use of the drills, and they just drill out the lower portion of the lamina in order to make some space for going in for further instruments. Now in here we can see that we have done a minimal amount of the drilling in here. We can see uh, we can see that the ligament film has just started to come into view, and a very beautiful space has been created, and we don't need any more further type of space for going into any further. So The thing what we can say is here, as we are going in inside, we can see the lamina has again been exposed. The 6 o'clock is towards the spinous process. We are standing on the left side of the patient. Simple bite side punch with the help of a number one or a number two will do the work. A small bite of the lamina is being taken out, and we don't need to take out the whole of the lamina at all at any point of time. Until and unless the ligament flavum is totally intact below the spine, above the canal, we are safe, and we don't need to take out our basic instruments at every point. The fluid does our work. It washes out the bony material. It washes out the other small fragments of the whether it be soft tissue, whether it be bony material. The fluid do the rest of the work. So in here we can see the help of the small punches. We are just removing out, and with repeated usage of drills, with repeated usage of punches, and with the repeated usage of our wand, we try to make further space over here. Once the space is being built, we can see we can see the ligament flavum has started to come into view. Now the important thing is, if we have to go for a plain discectomy or for a simple nerve compression, we don't have to remove the total ligament flavum. It has to be the essence of minimal invasive. It's not just the small ports, or it's not just the usage of endoscope. It's the minimal destruction or the minimal removal of the normal bone or the normal material, and doing the maximum amount of the work for the patient. So in here, the incision won't be doing a second matter if we are telling the name of minimal invasive. Basically, minimal invasive spine surgery or any type of surgery, it's a philosophy. It's not just the usage of endoscope that we would be saying, okay, it's minimal invasive, as we are using an endoscope, and we are removing the whole of the lamina, and we are removing every bit of the ligament flavum. No, we have to remove only that portion that is required till we reach the specific site, or till we reach the pathology. So again, ligament flavum sparing ligament flavum removal should be performed. If this had been the case in which we had to remove the whole of the ligament flavum, I would have drilled more towards the medial side till I reached the median cleft. From the median cleft, I would have removed the whole of the ligament flavum. In here, since I have to deal just over the portion lying over the nerve root, I'm just trying to remove a part of the ligament flavum that is surrounding my nerve. So in here, I can see that with the repeated usage of, I'll just show in the other one. We can just see that with the repeated usage of my punches, I can just separate and remove the ligament flavum. In here, I can see that the nerve has started coming into view. I'm just trying to visualize my nerve in here. Now, as the nerve has started coming into view, I can take the help of one more instrument. I can just slide with the help of a plain hook, or it be a round ball hook. I can just take the help of it, and I can see that the nerve root is going towards the lateral side in here. I can see the compression going from below. Now, in here, what I want to emphasize is the usage of the first instrument. Either I can use a semi-tubular retractor which lies with the help of the instrument which goes with the instrument, or I can take that help to retract the nerve root. Initially, I can just use my plain instrument, the disc process, but I should be very, very careful with using of the disc process, as I might injure and take a piece of the bite of the dura along with the disc process. So both my ends of the instrument should be very clearly visualized till I grasp and pull out anything. Anything should be very well, it should be clearly visualized. So in here, I can see that help of one instrument, I'm just pulling it, I'm just retracting the dura, and with the help of the another, I'm just trying to take out small pieces uh, of the disc material. In here, I'll just show you another case in which it was a very, very soft, juicy disc, in which firstly I can see that I'm standing on the left side, my pathology is on the right side. As we can see that the nerve root, as it starts coming into view, it's going towards the 1 or 2 o'clock position. So my dura is towards the 9 o'clock position. My midline is towards the 6 o'clock position, and I can see that the juicy disc is just starting coming into view. And in here, with the help of disc process, both the ends of the disc process, it should be very, very clearly visualized. Small bite-sized pieces start coming into view, and I can take the help of other instruments also. I can take the help of a plain hook forceps, or with the help of a small ball tip probe, in order to just retract the nerve root. and just with the help of retracting upload towards one side, I can once again push my disc forceps again through the same opening as through which I placed my nub hook, and once it goes inside, see, I can see the two instruments are being used along with the scope. One is just retracting the dura, and the other is just taking out the rest of the disc fragments. Now, once it has been done, one of the most important thing is annuloplasty. Where my RF band is placed, it's over the shoulder of the nerve root. I will just seal out the place from which the disc has come out. I won't be cleaning out the complete disc. It's not required at all. Just the essence of minimal invasive spine surgery should be followed. The portion of the annulus through which the disc has come out, it should be completely sealed out. Now, once it has been completely sealed out, as we can see, we can just take out our completely outside. Drain is being placed, and once the drain has been placed, the scope coming out of the port, and we can see that all the muscle is falling back into its place. That's the beauty of this thing. So this was just a small clearance of showing the effect of the surgeon standing on the left and directly dealing with the pathology on the right side, on the right side of the patient, and not removing any portion of the lamina on the left side, just directly attacking the pathology on the right side. It's a wonderful technique, again, UB for right side pathology with a left standing approach for right-handed surgeons. Accurate port placement is the key, and adequate pressure in the working cavity is the number one thing to control the bleeding. So all in all, to summarize it all, so these points, I would just go back to for an anecdote with this image. So it was in 1847 when a surgeon named Robert Liston, he amputated a man's legs in 2.5 minutes. But it was performed so quickly that he accidentally amputated the fingers of his assistant as well. So both the patient and the assistant died from gambling, and another spectator he reportedly died from fright. So this is the only reported surgery in history with a 300% mortality. The patient, the assistant, and one of the spectators, three people died. So all in all, any type of surgery, we need to go completely with the right indications, the right approach, the right instruments, and again with the right mentorship for a very successful surgery. Thank you all. Thank you.
One moment. Professor Ansari, thank you very much. Thank you very much. Actually, I think you have convinced all the auditorium in the benefits of method you presented. So maybe there are some questions from the floor, from the auditorium. I do not see. No?
We
Yes, I
can
can.
see a raised hand by Dr. 𝑵𝒆𝒊𝒈𝒁, you have any comments?
Thank you, sir.
Dr.
It
Wisek,
was
are
a
you here?
wonderful presentation. Yeah. Can you hear
Oh,
me?
Yes.
Uh, can you hear me, Ben Sensei?
Yes.
yes, please. Yes, please. You can ask your
Okay.
question.
So thank you. Wonderful presentation. Last week we have talked about the PSLD. Now today the UB. A couple of questions, sir. As a starter, which system I should go with? Should you go with the UB system or the PSLD? I mean, what is the advantage, disadvantage in terms of indication and contraindication? Is number one, and number two is from the technical aspect. What are the radiological assessment we should do before we select the patient for the UB for the lumbar discectomy, like L4 or L45 or L5S1? This is number two, and number three is where should we make the port? If I'm a right-handed person, I'm standing on the left, and the patient's pathology is on the left side. I mean the caudocranial distance and the mediolateral distance.
Yes, these are very interesting questions. Regarding your first question, whether going in for a PSLD or going with a UB, see, I have used both of the systems. The main problem which arises with the PSLD, the stereoscopy system, is the scope as well as the instruments. They are going through a single portal. Okay, so you are seeing exactly where your instrument are standing out. Okay, so you at times for a fresher they don't have much of the freedom of moving with the left hand along with the along with the instrument which is right which is handing in the right side, because it is just through a single port. With UB, one of the port is exclusively for the scope. The other hand is totally free. So you have a very wonderful area of freedom. It's just exactly like a microscopic surgery. If you have made a beautiful space inside, it's exactly like a microscopic surgery. So for starters, for at least for me, I would say that UV would be better as compared to PSLD. So both techniques, they are wonderful techniques. With regards to the giants in this particular field, whoever are using it. Regarding your second question, where exactly you should be making your post. So if you are a right-hand surgeon and the pathology is on the left side and you are standing on the left side of the patient, the first incision, but the first area of marking is the midpoint. Okay. The second point is your C-arm. It should be exactly over the disc. Both the end plates of the vertebra, it should be clearly visualized.
Clear.
For that matter, you might just turn your C-arm at the 10 to 20 degrees as regards the parallelity of the end plates. So both the second lines are should be above the end plates. Okay. The third line, the marking should be the medial margin of the pedicle. Okay. The fifth line, it should be midpoint of medial markings of the pedicle. It should be incising at that very particular point. Okay. So now
Hmm.
all these markings have been done. Your incision, if it's just a nerve root decompression or a disc decompression, if it's just on one side, it should be midway between spinous process and the facet joint. Okay. For starters, an incision which is transverse is very helpful. Why? Because as you are moving your hands, it is mostly towards right left side. It's not cranial cordon usually. Okay,
Hmm.
so a transverse incision is relatively it's relatively very helpful. For me, for longitudinal incisions, for simple cases whether it be nerve root decompression or a discectomy, it's very helpful because it merges with the patient's back and hardly leaves any mark. Of course, if you are going in for a fusion surgery, again your
Hmm.
incision should be way lateral because you have to deal directly over the facet joint and you need to decompress right from the facet joint going towards the lateral side. Okay, so your
Okay.
incisions will decide according to the pathology you are dealing with. Okay, so there is no hard and fast rule that your incision should be exactly at the level of pedicle
Mhm.
and you should be moving exactly at the paramedian thing. Everything depends on the case to case scenario. Where
Yes,
exactly is
sir.
the pathology? Okay, and for starting for making an incision, it's best to use two spinal needles. You can place two spinal needles initially. You can see the triangulation that they are making, and then you can make the incision. Okay.
Sir, just one supplementary question. For the downward or upward migrated disc, I mean, if the scope needs to be angled downward or upward, how do you make it?
Again, UB is a wonderful technique. Your one hand is totally free. You can move the scopic hand, that is the left hand, relatively by as much as 60 degrees with related to the horizontal line, and the other hand can go directly towards that direction. So you can make a pretty huge area inside with two very small incisions. That's the beauty of UB. With regard to PSLD in the starting phase, you might have some problems with this phase, the down migrated as well as the single level disc. If the disc is directly at the level of disc space as well as if it's going downwards, you might have some trouble with PSLD system. But UB again in this case, I would say that it's very helpful.
Oh, okay. As I hope to contact with you later, sir.
Yeah, sure, Viswas.
Thank you, sir.
Thank you.
Okay. Okay, thank you. Any more questions from the auditorium? No. Can I invite Professor Pizzart? Maybe you have some remarks and comments. Professor?
Thank you, Dr.
Yes, Salam alaikum.
Professor?
Greeting. Thank you very much, Professor Ansari. It
Alaikum.
was good achievement and congratulations, Mubarak. Thank you very much, and Professor Kato, you and all colleagues, especially Dr. Bakhtiar Burhani, is one of our Afghan neurosurgeons also present here. You're welcome. Thank you. It was excellent presentation, and we learn a lot from you. Thank you very much.
Thank you.
Thank
Dr.
you.
Butcher?
And
Yeah,
Dr.
you have
Wakil Ramona? Do you have some comments? Petra?
Oh, hello. Thank you, Dr. Bosnia. Thank you, Professor Ansari, for the time. I think this is a very important question because if people have not done biportal surgery, maybe they don't really get the issue. But for a right-handed surgeon, standing on the left or the right is very different, I think, for me. Maybe one of the parallel is maybe if you're doing some sort of retrosigmoid with a guy with a big shoulder, you find some difficulty moving your hand because it's blocked. But for the biportal, it's blocked on the inside because the bony structures is very difficult. Professor Ansari, I have one question for you. Because standing on the other side is no problem for a posterior pathology, but for an anterior pathology like a disc, do you recommend standing on the other side? Because some people are concerned you may have to retract the tackle sac too much if you want to reach the anterior side from the contralateral. Thank you.
Yes, of course, Dr. Petra, wonderful question. So if the pathology is dealing with the it's mainly towards the right side and it's going towards the midline as well. So meaning thereby the patient has majority of the symptoms of the right side, but he's also got symptoms which is crossing towards the midline also. In that case, I would say that standing on the right side of the patient is very, very beneficial because in those cases we have to make our angulation very, very steep. We have to go over the shoulder to see towards the midline. So in those cases, as I've shown in one of the videos also, standing on the right side is very, very beneficial. Just the only thing which makes the problem with some for some right-handed surgeons is your scope, which is in the left hand, it goes down. It goes towards the leg end of the patient. The instrument hand, it's again as it is on the right hand of the surgeon. It goes towards the canal side, which is what most right-handed surgeons are not familiar with. So that exactly is the main problem with most of the surgeons. Otherwise, the drilling thing, everything remains the same. The only important thing is for standing on the left side, we have to clean the cranial portion of the lower portion of the cranial lamina. In this case, also we have to clear the lower portion of the cranial lamina. So standing on the right side with the instrument on our right hand, at times it might be problem for some surgeons to reach the lower border of the upper lamina. So that might be a problem. But for pathologies which are predominantly on the right side and they are going crossing towards the midline, standing on the right side, as we had said, it's way, way beneficial.
Thank you, Professor.
Okay, thank you. Well, let us move on, and I'm inviting Dr. Opara. She will present us his talk dedicated to malignant neurofibroma in a patient with NF1 syndrome. Dr. Opara, are you ready? Yes, great.
Yes, I am.
Okay, you can start. Hello, you can start.
Okay, wonderful. Thank
You can
you.
you just share
Let me
your
just
screen.
try and share my screen.
Yes,
Yes,
please.
let me do that now. Just give me a few seconds.
Mhm. Okay, that's good. Good. You can start. So
Let me start. Let me try to
Yes.
start from the top.
Yes. Go to the beginning.
Okay,
Yes.
there we go.
So,
Okay, can you still hear me? Can you still hear me?
Yes.
Yes, we can
Okay,
hear,
good.
you can see. So please go. Please start.
Okay. Thank you so much. It's morning here in Nigeria. So good morning, everyone. It's a big privilege, and I want to thank the ACNS and Professor Kato for this opportunity and privilege to share this case report. A giant scalp flexible neurofibroma with malignant transformation. And I'll use this outline. Neurofibromas are usually benign tumors of the nerve sheath. but they may occasionally become malignant. And this case report discusses a giant scalp neurofibroma that weighed up to 8 kilograms and underwent malignant transformation, metastasizing to the chest. The patient was an 18-year-old female with an occipital scalp mass noticed since birth, initially of a small size, and had been progressively increasing in size over the years. But in the year preceding presentation, there was a rapid increase in the size of the mass. The mass became even bigger than her head size. She also had other skin lesions all over her body. On examination at first presentation, there was a huge occipital mass about the size of a head, about 20 by 18 by 16 centimeters in its widest diameters then, with areas of ulceration at the summit of the mass and associated surrounding large scalp vessels. She had multiple 𝒂𝒊𝒈 spots all over her body, and there are also small cutaneous masses all over the body as well. She was worked up for diagnosis and preparation for surgery. This was an MRI she did. You can see the mass there at the back of the head. It's way bigger than the head itself. So she was prepared for surgery, and it took some time because she had to be transfused severally due to anemia. Consent for surgery was obtained, and the patient really wanted the surgery to at least relieve the heavy burden on her head, and of course the social her social well-being, because she hardly could go out, and when she goes out she has to cover the mass with a scarf, you know. So she really wanted to have the surgery done. Intraoperatively, there were some anesthetic challenges, obviously, with having to intubate the patient. So we had to hold the mass to be able to allow the anesthetic team to intubate the patient. The surgery was done in combination with the plastic surgery team due to the large mass and our worry for closure, skin closure afterwards. Because of the risk of bleeding intraoperatively, we used the harmonic scalpel to help raise the scalp flap. So this is a picture of the patient already on table, and it's sizable, the head in the head positioned prone. You can see the mass there, how huge it is, with the extension of the lesion within the scalp there. There's a green mark on the skin. I don't know if you can see it clearly. That was our marking points for where we would put our incision. This is it from the back, and you can note those multiple skin nodules I spoke about. You can also note the 𝒂𝒊𝒈 spots on her body and the ulceration of the mass at the summit there. This is her from the side. Okay, so we had a near total excision of the mass, near total being that the skin was infiltrated with a lot of masses, and we didn't want to take it all out so that we could have adequate skin cover. Our thought was, when we take this large mass out, she could continue with radiotherapy later on to sort out whatever was left in the tumor bed. Her estimated blood loss was about 2 liters, and we closed the wound in a new shape, as you can see here. This was before suture removal. So stitches were removed on day 14. She was discharged home. She was due for follow-up in 2 weeks, but she didn't show up. And multiple attempts to reach her were proved abortive because the number just wasn't reachable. Eventually, about 6 weeks later, we were able to reach her, and she complained of catching a cold after discharge. So we prevailed on her to come back to the hospital so that we could find out what the cause of the cold was. And when she came, we got a chest X-ray which showed homogeneous opacification in the entire right hemithorax. Cardiothoracic surgery consult was sent, a chest tap that yielded a dry tap, so we had to ask for a chest CT. And this chest CT showed a solid mass in the entire right hemithorax, as you can see in the image there, and something on the left hemithorax as well. By this time, she was already in severe respiratory distress, and what else can we do for this patient? So we counseled the family on the poor prognosis and the different options that she could have. However, she demised 3 days after doing the chest CT. The histology results came afterwards and returned as intermediate grade soft tissue tumor with features favoring malignant peripheral nerve sheath tumor. So let me just quickly give us a quick rundown on neurofibromas and especially neurofibromatosis 1. Neurofibromas are benign peripheral nerve sheath tumors, and they could be sporadic or associated with neurofibromatosis. Some people have classified it as localized, diffuse, or plexiform. And when you see the plexiform type, it is pathognomonic for neurofibromatosis 1. And in neurofibromatosis 1 is a clinical syndrome that presents with various cutaneous lesions due to a defect in the neurofibromin 1 gene, which is found on chromosome 17. Now, in neurofibromatosis, the lesions are usually seen near the spinal cord or brain and on common sites like the tongue, parotid gland, and so on and so forth. 10% of neurofibromatosis 1 plexiform lesions eventually turn malignant, as we had in this patient. Now, the diagnosis of neurofibromatosis 1 can be made clinically using a set of diagnostic criteria. Neurofibromatosis 1, if 2 or more of the following if you have 6 or more 𝒂𝒊 spots, if there are 2 or more skin nodules, as we saw in this our patient, there were many skin nodules on this patient, or if there is 1 plexiform neurofibroma, and then if there are axillary or groin freckling, if there are leash nodules, which are hematomas on the iris, then patients could also have bone deformities, usually of the sphenoid wing or of the tibial bone. Patient may have optic pathway gliomas, and then if there's a first-degree relative with clinically diagnosed neurofibromatosis 1. So any patient that has 2 or more of the following 7 of these 7 clinical criteria is said to have neurofibromatosis 1. So we made our diagnosis based on that for this patient. Now, malignant peripheral nerve sheath tumors in particular, they have a very poor prognosis. 1, because of their widespread metastasis, and also because they have a high rate of local recurrence. And usually when a patient who has a plexiform neurofibroma now begins to complain of pain and rapid enlargement of the mass, you should consider that it is becoming malignant. And that was the case in this patient. Unfortunately, we lost her a few weeks after the surgery. So in conclusion, neurofibromas can grow to really and really increasing size of a long-standing small cutaneous nodule. Suspicion of malignant transformation and full workup should include that possibility to search for likely deposits. Whenever needed, multidisciplinary management should be done. And this mass was a really large mass. When we weighed it intraoperative, after taking it out in the theater, it was up to 8 kilograms. So it's a very large scalp mass. Thank you very much for listening.
Thank you, Dr. Opara, for great presentation. Really, my congratulations. Really an interesting case and very good literature review. So, do we have any questions from the floor? No. Any comments, Dr. Wahyou Pramono?
Professor, Yes, and thank you, Professor 𝒊𝒂𝒂, for this
Yes.
interest. Sorry, can you hear me?
Yeah, Ben.
Yes, I can.
Yeah, okay. And
Yes,
thank you,
yes.
𝒊𝒂𝒂, for the this very interesting case, and I feel sorry for this young kid to have such a malignant disease. So I would like to ask about some more details with the surgery. The first is that I think in your presentation you mentioned that the skin was involved. So how would you plan your incision and to aid with the reconstruction of the skin during the closure? Do you excise the involved skins with a margin, and then you reconstruct it with a flap, a local flap, or you leave some of the skin behind? Another question is about how about the underlying bones? Are they also involved? And do you need to drill them if it's involved? Yeah, thank you so much.
Sorry, the last question, you said the underlying what? Bone?
The bone. The bone.
Bone.
Is the bone involved?
Okay.
Yeah.
Okay. Okay, can I answer those?
Yes, please.
Professor, can
We are
I go
listening.
ahead? Okay, thank you. So
Yes, please. Yes.
as I mentioned during the presentation, when I was showing the patient lying on table, I'm not sure if you were able to see the green skin marking lines we put on the mask to show where our incision lines would be. So we, in conjunction with the plastic surgery team, we tried to raise the flap because you can see that the mask had pushed out. We had a lot of skin all over the mask, right? So we tried to take advantage of that excess skin to plan the closure. So we didn't have to raise any other flap from anywhere. We just raised around the mask. I don't know if I can go back to the slide and show us those areas. Unfortunately, I don't have a pointer to point exactly how we drew the markings around the mask. Let me just go back and share my screen if you don't mind, please.
Okay.
Okay, now can you see the screen?
Yes.
Yes. If you look on the scalp towards the towards the frontal part of the head, or towards the head itself, this because the scalp, the mass is so large, but towards the head itself, you can see two green lines, almost like an X. Can you see those?
Yes.
So those lines represent how we were trying to raise the skin flap. So we raised it as a curvilinear incision round the mass on the four sides, right? Curvilinear. So when we were done, this is how it turned out. This is the frontal. Sorry, I don't have a cursor to use. The frontal part of that scalp incision, then the sides, and then the inferior part. So we were able to close it in this U-shaped fashion. I don't know if it makes sense.
Yes, understood.
Yes. Now, for the underlying bone, from the pre-op imaging, of course, what I showed was the MRI. We didn't see anything. I mean, we can't really assess bone on MRI, but we could see that the mass was not extending into the cranial cavity. But intraoperatively, there was some bony defect. But we didn't want to chase that because one, we already had a lot of blood loss intraoperatively, and we had already decided that we don't have to take out everything. We just want to relieve her of this large mass burden, and if necessary, she can go ahead to have radiotherapy afterwards. So we didn't go around chasing any other thing. We just took out that massive thing we could see. We even left, there were some skin nodules, we could see on the scalp, the skin of the scalp, but we left those ones, just took out the major, the really large mass and closed. Okay. Those are the two questions I had. I don't know if there are more questions for me.
Okay, thank you, Dr. Opara. Dr. Ben, are you satisfied? It's good. One more question.
Yeah, thank you.
Thank you. I see we have one more question.
Yes.
Yes, please.
Greetings. Thank you, Dr. I'm sorry for pronouncing Opara. Thank you for the brilliant presentation. It was an amazing case, and I was wondering about the amount of blood loss. I could imagine it could be like this kind of mass would be well fed with the new arteries and veins. Like, did you go directly to the surgery? Did you consider embolization prior to the radical excision of the tumor?
Thank you very much for that question. Can you hear me?
Yes.
Yes, yes.
So thank you very much for that question. Yes, embolization can be considered. However, in the environment I work in, we don't have that option, right? So this is why we even had to discuss with the plastic surgery team. They have the harmonic scalpel. They are the ones that usually use it. So we had to use that to help to raise the scalp mass. But despite that, it was still there was still a lot of bleeding. So what we usually do in this situation is we ensure that before surgery we had enough units of blood. So that should prepare for us at least 6 units of blood. We'll let them know we're going into theater, so that in case we still need more, they can get us more, so that's what we do in our environment. Thank you for the question. Very wonderful.
Thank you very much. I can also relate because I'm coming from developing country in Georgia, so I can relate to that. Thank you very much.
Yeah.
Okay, great. One more questions? I don't see more questions. Any comments?
Dr. Wozniak, if I may.
Yes, please, Dr. Wahyo-Pramono, please.
Dr. Opara, thank you for the presentation. I want to ask you, it's 6 weeks when the patient returned to your clinic, but she already has a very big chest mass. Do you think that this mass is already there from the first surgery, or do you think it's because we did some resection and then there's some distal seeding that become that mass? Thank you.
Yes, thank you very much. That was a very important question. So we thought of this, and the thing is, before surgery, we had done a chest X-ray, and we really didn't see anything suspicious on the chest X-ray. So we don't know if there was something there that couldn't have been picked. We're not sure. Maybe it was small and we didn't know. But on the chest X-ray, pre-operatively, there was nothing on the chest.
Thank you, Doctor.
Thank you.
Okay. Thank you. Dr. 𝒕-𝑺𝒊𝒂𝒏, Professor 𝒕-𝑺𝒊𝒂𝒏, few words.
Thank you. Thank you very much, Dr. Opara. Amazing and huge, good achievement. Thank you. Thank you very much.
Thank you, Prof. Thank you so much.
Let me use my privilege as a moderator. I have some comment according to this presentation. First of all, Dr. Opara, thank you very much. Really interesting topic because of many because of many aspects. First of all, the NF1 is very rare pathology, and we always must be very attentive with our patient to separate this group of patients from general cohort. We meet it not very often, about 1 per 3,000 in population. But why it's important? Important because the patient with an NF1 is in much higher, about tenfold risk of any malignancies compared to general population. So the patients must be actually observed regularly in terms of some new malignancies, not only typical neurofibromas, but other malignancies, and it's proven that this group of our patients are really in high risk. So thank you again for very interesting presentation and for emphasizing of this problem with the auditorium. If we have no comments and questions, I want to invite our keynote speaker, Professor Oya, with the topic about challenges of surgery of petroclival and petrotentorial meningiomas. Professor Oya, are you ready?
Yes, thank
You
you,
can
Professor
start.
Wozniak. Yes, let me share my slides. How about that? You see my slides?
Yes.
Okay.
So please go on.
Thank you. All right. Thank you. Thank you for inviting me to this webinar. My talk is about our current variations to treat petroclival and petrotentorial meningioma resection. In resecting skull-based meningiomas such as petroclival or petrotentorial meningiomas, of course, functional prevention and long-term tumor control should be achieved in a balanced way. However, these tumors frequently occur in areas where cranial nerves run in a complicated way, and cranial nerve deficits frequently occur after surgery. And cranial nerve deficits greatly reduce the quality of life of patients. Even recent literature like this emphasizes that achieving the high resection rate and maintaining the quality of life of patients is very technically demanding. And another meta-analysis revealed that the cranial nerve deficits occur in 34%, and the motor deficits in 14%, and the CSF leak in 5%. So let me share our basic surgical strategies with you. Of course, safe maximum resection is kind of a central dogma. And we treat patients with adjuvant radiation therapy after surgery based on the postoperative pathological information. And when we determine the surgical goal, we take some specific factors into consideration, such as patient's age or comorbidities. And also, we are not hesitant to flexibly modify the surgical goal according to intraoperative findings, such as the tumor consistency. And we choose the approach by which we take out the tumor without pushing or irritating the cranial nerves. Consequently, our approaches include transpetrosal, retrosigmoid, or endoscopic transcoival approaches. And if operation time is expected to be longer than 10 hours, we plan stage surgery. This chart shows our surgical outcome of 49 cases of petroclival or petrotentorial meningiomas. And as you see here, the incidence of the cranial nerve deficits are lower than those of the previous meta-analysis I mentioned. However, I take this to be an unsatisfactory result. However, at least I think I can say we may be able to start reducing the complication in a trigeminal nerve injury, as you see here. So let me share with you how we avoid facial numbness after surgery. This patient had a right side 𝒕𝒊𝒈𝒂𝒏 meningioma. And we divided the surgery into 2 stages. The first part was done by a young colleague. And now he is doing via anterior 𝑇rans-𝑃𝒊𝒈𝒂𝒏 route born and the posterior partial 𝑇rans-𝑃𝒊𝒈𝒂𝒏 born. And anticipating the second surgery, we placed the Gore-Tex on the bone flap to prevent the adhesion. And 2 weeks later, we brought her back to the OR. And you see, this is the 4th nerve. And the first thing I'm going to do is to cut the 𝑀cKells-cave dura and open the 𝑀cKells-cave and remove the tumor invading the 𝑀cKells-cave. I used not to do this, but after I just try to stick to this strategy, I am feeling that the incidence of the trigeminal nerve injury is getting decreased. Now I'm opening mobilizing the 4th nerve by cutting the 𝒕𝒊𝒈𝒂𝒏𝒂𝒃 ligament. And now I'm doing the internal debulking. Sometimes I use navigation to remove the subcapsular fascium. And now I'm removing the tumor, the posterior part. This is the 𝒕𝒊𝒈𝒂𝒏 vein. I decided to leave this flow via the 𝒕𝒊𝒈𝒂𝒏 vein towards the cavernous sinus. And now I asked my assistant to protect the 5th nerve. Possibly even these seemingly minor, the constellation towards the cranial nerve will decrease the incidence rate of the injury. You see, I found the 6th nerve around the brainstem. I used to look for the 6th nerve around the Drell's canal. However, the dura around the Drell's canals are involved in the tumor attachment. So I changed my strategy. First, I look for the 6th nerve around the brainstem, and I follow it towards, this is the Drell's canal. So I think this will increase the safety of the incidence of preserving the 6th nerve too. And this is the vascular artery. I try not to remove all the capsules covering the brainstem. And this is the upper part of the tumor. You see, this is the 3rd nerve. And I could preserve the venous flow via 𝒕𝒊𝒈𝒏 vein, 𝒕𝒊𝒈𝒂𝒏 vein, and the cavernous sinus. And this is how we reconstruct the skull-base dura. We use the artificial dura soaked with the fibrin glue to cover the drilled temporal bone. And we also reinforce this place by a pedicle peritoneal fascial fat. We put the fat pad to fill the dead space. So she had no facial numbness. This is important from my standpoint. Although she had slight 6th nerve palsy to some extent that she's not concerned about, but she had no facial numbness. The second case, I will show our way to protect hearing. This patient had right pituitary tentorial meningioma causing worsening hearing disturbance on the right side. So the main purpose of this surgery is to preserve her function, hearing function. To fulfill this function, I think we tried to protect the semicircular canal. You see the head of this drill is a 4 millimeter. That's very good guide for you to the range of the drill. And I also try to preserve the end lymphatic sac and the duct to preserve the hearing function. And I used to complete all the extradural drawing before I opened the dura in anterior transpetuous approach. But I just quit because now we have a nice drill for skull-based drawing. So I leave the petrous apex, and then I proceeded to opening the temporal dura and cut the tentorium. You see, this is a tumor. That's the fourth nerve. And the basic principle is the same. The first thing we have to do is to the tumor debulking, and then we get outside the tumor. And I found the vascular alley and also oculomotor nerve. And if you take the right step, you can mobilize the tumor, and you can roll the tumor. And then I cut the pre-sigmoid dura. Well, I decided to leave the dura of the temporal base because there was a thick intradural vein covering the right temporal lobe. So now I did additional drawing to open the internal auditory canal. I think this strategy will minimize the risk of the CSF leak because I just drilled only the range that I need to open. And also, if you want to preserve the patient's hearing function in the long term, I think you have to take care of the tumors invading the internal auditory canal. So I sometimes use the endoscope to confirm the total resection of the tumor inside the canal. And then all the cranial nerves and the venous structures were preserved. And we could preserve her hearing function, although she had a transient fourth nerve and fifth nerve deficits, but these recovered very well. The third case, how about the third case? This patient was a 79-year-old lady. I mean, the elderly patient. So we like to, minimize the surgical risks or invasion. So I try to relieve her pain with minimal risk and chose retrocircular approach for this tumor. But even with this approach, you have to preserve the venous structure as much as possible. Now, I'm using the retractor. Some people do not advocate the use of retractor, but I think this is very important technique. I'm holding the cerebellum, not pushing or not damaging the cerebellum. And also, in this type of tumor, usually the tentorium get very thick because of the abundant feeders. But if you cut the tentorium like this, you can see the fourth nerve very well. This is the fourth nerve. And I'm not, hesitant to leave small residuals near the cranial nerve. And as a result, our facial pain gone, and the result was good, and she was very happy. And recently, endoscopic transcribal approach is a very nice option for this type of the tumor originating from the midline of the cribus. Although you have to take care of the CSF leak, but this approach is the best to preserve the cranial nerve. So you see, this is the transnasal endoscopic approach. And you have to drill the cribus as widely as possible to the point just medial to the bilateral jugular filaments. And another tip is you go outside the tumor and gently, after the internal debulking, gently pull the tumor, but you should confirm the tumor capsule or tumor itself does not encase the cranial nerves or small perforators. And luckily, this tumor had little adhesion to those structures. So the tumor was safely removed without pushing the cranial nerves, nor any vascular complication. And we use the multiple dural reconstruction technique like this, reinforced with the balloon compression. And she was completely fine after surgery. Near total resection was achieved. However, on postoperative day 15, she had fever and developed to have meningitis. So we took her to the operation room immediately because we know the CSF leak leading to the brain abscess is life-threatening. So we saw some CSF leak from this fissure. So we performed several stitches. We added several stitches to make this point watertight. And I think this is very nice technique. We reinforced the suture line with 5-ingredient soaked small fat piece. We believe that this will increase the safety of this reconstruction technique significantly. And she was completely fine. And in this last case, I like to emphasize that we should tailor our surgical goals depending on the patient's condition. This patient had very severe symptoms shown here, but she was on chemo for her lung cancer, but she could not walk and she couldn't eat. So we performed endoscopic transcribal resection of the tumor, but the surgical goal for her was determined to improve her condition of oral intake and walking. So compared to the previous case, our bony window is some sort of slightly smaller. And then we cut the dura on the midline and then remove the tumor. So the main purpose of the surgery is the decompression of the brain due to the tumor. So we go outside the tumor and see some vital structures like a 𝑹𝒊𝒈𝒉𝒕 or sixth nerve here. However, we just decided to leave a small tumor covering this important structure. We are shaving the tumor by cursor. But we of course we have to take care of we have to prevent the CSF leak completely. And all symptoms are resolved, and she became able to walk, and she was back to her original hospital for continuation of the chemo. So thus, to select an approach that allows us to remove tumor without touching the cranial nerves is the best in most cases. However, we sometimes have to modify this principle, considering what's the best for each patient in resecting this formidable tumor, such as 𝒕-𝒌𝒄𝒉 or 𝒕-𝒌𝒄𝒉 meningiomas. Thank you very much.
Thank you very much, Professor Oya. Great, impressive presentation, excellent cases, and incredible technique. surgical technique. Thank you.
Thank
Any
you.
questions from the auditorium? So please be more active.
And Professor
No
Oya,
question.
can
Yeah.
ask a question about
Yes.
Who's
yeah,
talking?
yes,
Excuse me,
thank you.
Ben?
Yes, it's Ben.
Is it
Can
Ben?
you hear
Okay.
me?
Yes, but your face is fixed, so I just okay.
Okay.
Go ahead.
So yeah, and congratulations on your cases and with the endoscopic approach to the kyphal lesions. So I would like to ask about several things concerning the techniques. And the first thing is I saw some of your cases, and the lower extent of the tumor extend to around C1 wings. So, and I can see that your post-op scan, you're only drawing the lower aspect of the kyphus is already enough to remove that. So, do you use angle endoscope to overcome the view obscured by the C1, or other techniques that you use if the lower extent of the lesion is obscured by the C1 and the tip of the C2? And my second question is about for the drilling of the jugular tubercle. So how do you define the natural extent of the bony drilling? It's quite difficult actually, and for us as a young neurosurgeon to start learning this technique. I attend some courses of this, but I would like to hear about your view. How do you determine the extent of the drilling of the jugular tubercle during this technique? And my last question is about the reconstruction. And so I can see that you use the you use the fasciolata and also the abdominal fat graft with a multi-layer suture. But how about the using the nasal mucosa or nasal septal flap? Do you also routinely use it? And do you think the length of the nasal septal flap is enough? Yeah, thank you so much.
Oh, thank you for asking. All your three questions are very important. And the second question is about the range of the drilling.
Yeah,
and,
the natural.
Yes, as for your first question, I think we can drill the C1 and the lower clivus to increase the exposure of the lower part of the clival meningioma. But in that case, we were not 100% sure that we could resect. We could approach all the attachment lower part of the meningioma. But when we use the angled scope, like a 30 degree, we could see. I just include some short scene or video in my presentation. So we could approach the lower part of the tumor, but we could not see the end of the attachment of the tumor. But still, we can approach the lower part of the tumor using the 30-degree angled endoscope. So I leave a very thin attachment, in the from the magnum area, and remove the almost all portion of the tumor. So I think it depends how consistent or how hard the tumor consistency is. Okay, and if you want to go low, need to go much lower, I think you can do it, but well, my experience is limited, so I don't have the correct right answer based on my experience. As for the lower part, but lateral part, it's yes, I understand that it's not easy for young surgeons to determine where is the jugular foramen or where is the limitation. I think the one easy solution is the navigation, but other than that, I think you should not hesitate to go intradural first, and then why if you are not sure where the jugular foramen is, just just careful, leave a small rim of the bone, and then you go into the intradural space, and then you can add the drilling anyway later,
Yes.
Okay. And the third one, reconstruction. Sometimes we use the nasal septal flap. So for example, the second case, the last case of the cryomeningioma for patients on chemo for her lung cancer, we use the septal flap because we no matter what, we did not want to have the CSF leak. So we just had to we tried to be perfect, but taking the nasal septal flap may reduce the sense of smell or sense of some nasal function. So we consider it last resort. Okay.
Yes, and can I also ask one more question about for those kyphal lesions? So, do you allow them to feed with oral feeding on post-op day one, or how long would you wait?
Well, first we need to see how patients goes. Like we need a few days, before resuming the oral intake. But if in the first a few days there is no sign of a CSF leak, we just let the patients. We allow patients to take things orally.
I see. Thank you. Thank you so much.
Thank you.
Excellent.
Thank you very much. Any more questions from the auditorium?
Maybe
no.
Opera, do you have any comments?
No. So okay, let us go to the comments. Yes, please. Dr. 𝒊𝒈𝒉𝒕-𝑺𝒊𝒂𝒏𝒄, can you comment?
Yes, thank you, Sensei. I think it's very wonderful the way you can dissect all the critical vascular and neural structures during these surgeries. Can I ask, in your experience, usually how happy are you to leave a remnant tumor near these structures? Because sometimes if you come from a retrosigmoid or a transpetrosal approach, it's very difficult to see the ones at the very distal end of the surgery. Do you usually use a gamma knife after that, or just a conventional radiation? What is your secret? Thank you, Professor.
Thank you very much. Yes, we of course we always have to think about the recurrence. Even a small, tiny residue can come back. However, the most basic researches on meningioma, biology showed that the meningiomas arising from the skull base, they are more benign than the lateral or convexity or 𝑹𝒊𝒈𝒆𝒅 meningiomas. They may be very aggressive, but most skull-based tumors are biologically benign, I think. And so I think we can make we can improve the patient's quality of life, especially for aged patient, elderly patient, even if we leave small mass around the cranial nerves or brainstem or some other vital structures. So that's why I'm not hesitant to leave those one. This is specific to simple skull-based meningiomas. So based on their radiological characteristics.
Thank you, Sensei. Also, do you use a gamma knife or conventional radiation after that?
Yes, yes, but we do not use the gamma knife as a adjuvant radiation. Always a salvage radiation. When we see the recurrence, we may use the gamma knife or cyber knife, but yeah, we just wait for the tumor to come back.
Thank you, Sensei.
Thank you. Thank you.
Thank you.
Professor Pizart, few words, please.
Okay. Thank you, Professor Aya, for achievement, and thank you. Congratulations, and this very advanced techniques and approaches, and excellent achievement. Thank you very much. Unfortunately, we haven't this technology and advanced neurosurgery in Afghanistan, unfortunately, and we hope one day we got this technology and also experience to do and serve for our people. Thank you.
Thank you very much. But
Thank
I
you.
always respect your work, even in the limited, the access or facility. You did a great job. Thank you.
Arigato. Arigato gozaimasu.
Thank you. I also have some comment. Again, thank you very much for excellent presentation, Professor Oya. You know that in the modern skull-based neurosurgery, there are two tendencies for using of surgical approaches. One is more aggressive, like proposed by Professor Goto, by Sebastian Froelich, and so on. And another tendency is more conservative, which comes from Professor Sami, Tatagiba, Ramina, and this cohort. And your presentation actually put the end of this dispute between more and less aggressive. The answer is that surgeon must be familiar with the whole spectrum of approaches and the whole spectrum of surgical techniques. And only after this, surgeon can select the patient for any kind of surgery, more aggressive, less aggressive. So if surgeon expect more radical removal with the minimal deficit after surgery, he works more aggressive. If he cannot provide normal functional result, he is less aggressive and rely on some irradiation. So that is why thank you very much, because I really impressed with your talk, and really impressed with the combination of different methods for different pathologies. So thank you very much. If we have no comments and no questions, maybe Professor Kato, maybe would you give a small comment, at the end? Professor Kato, are you with us?
Yeah, now?
Yes, Professor, please.
Okay, thanks so much. So this webinar is conjunction with the ISMINS, the Congress. That means it's a minimally invasive the society. So I think where Sensei demonstrated very beautiful, wonderful surgical skill. I think in future, I think it's getting less and less become once become a neurosurgeon. So I think how he can educate them, because that is a very special technique only for Dr. Oya and maybe some special neurosurgeon in Japan, maybe 10, 20, or maybe maximum, I think. So I think maybe another option will be coming up in the near future. I think such a biological treatment, something like that. Maybe I want some comment from Dr. Oya Sensei about your concept of the education for next generation.
Professor Oya?
You're asking the concept for educating young people, young doctors.
So.
Okay. You know, I heard that not many neurosurgeons want to do the long, long surgery or tough surgery. The skull-based surgery is kind of a representative of those hard work. So, but I think I try to educate. I try to show how rewarding to treat those patients, and I think those young people are very eager to learn. And if they see their patients beautiful recovering and returning to their normal life, I think that will become the motivation for young doctors to learn. So I try to minimize the risk of complication and success rate to for them to go home. And if I can continue to show that to young doctors, I think more young doctors will, will feel willing to learn skull-based surgery. That's our task, I think. And also, we should provide the on-the-job training opportunity for young doctors. So, I try to let the young doctors do some part of the whole surgery, like a drilling of the posterior wall of the internal auditory canal. And so that kind of step-by-step process will also facilitate, fascinate young doctors.
Thanks so much. Because such kind of Africa, so many countries such Afghanistan, they may have such a large or giant pathology, I think, but even they do not have a gamma knife or fantastic treatments. Maybe I think you can show them the video and also the hands-on workshops and so on. I think you need to educate whole world, such kind of underdeveloping countries. And Ansari and also the May, thank you very much for your great talk. I think we are very proud of you. Thank you very much.
Thank you, Prof.
Okay, thank you. Thank you, Ron. So, Professor Kato, can I conclude our
Yes,
webinar?
please, of course. Yeah.
So thank you very much. Thank you for speakers. Thank you for participants. The webinar really, I think we had a very good discussion, very good presentation, and our young colleagues got a lot of interesting information for their future work. So thank you, and see you next time at the ACNS webinars. Thank you.
Thank you very much.
Thank you very much.
Bye.
Bye.